on Zoom. So now I have a background up. So for those who haven't been on before, I am Stu Cohen. I'm an infectious disease doc, the chief over at UC Davis. I have enjoyed being on these sessions and have hopefully provided a little bit of a different perspective. So in the hospital, we still have a significant number of patients with COVID hospitalized. So compared to, say, a month ago, we have less, maybe half, but we still have a fair number. There's still about a quarter of them, or maybe a third, are in the ICU. There are more kids, and the majority, when we know their vaccine status, are not vaccinated. In fact, we don't have a single person in the hospital that we know has had 2 doses of vaccine. So the way our data are collected, we don't have information on everybody, but there's not one vaccinated person who's been hospitalized. On the other hand, our healthcare workers are getting some breakthrough infections. They're all relatively mild. The number of healthcare workers who have been positive in the last handful of weeks, about 50-50, vaccinated versus unvaccinated. I think sometimes that's a little bit deceiving as to how effective the vaccines are, because if we have 90% of our healthcare workers being vaccinated, then only 50% of them being, of the positive tests being healthcare workers, means that the vaccinated people are proportionally underrepresented, and that shows protection. And it's keeping people out of the hospital. So I know there's a lot of buzz about 3rd doses of vaccine. That's part of the reason I was a little late today, because the CDC had voted against all healthcare workers getting a booster dose of vaccine. And so I think there's a little bit of, right, everyone was lined up and getting ready to get dosed, and now they're not. So I think there's going to be a little bit of a challenge involved in all this and figuring out when they're necessary. I think, in my perspective, and then I will be quiet, in my perspective, there are 2 reasons for boosting. One is the individuals, right? So even mild disease can sometimes drag on for a period of time. And then the second is that vaccinated people can potentially transmit, even though it may be for a shorter period of time, and it may be less likely to be associated with transmission than somebody who is not vaccinated. And so from a let's get COVID over with point of view, the less people who are infected, the less virus is going to be circulating, the less transmission. So it helps the individual, which is the most important thing. But it is overall a benefit, I think, to all of us to have less virus floating around in Sacramento and get the whole, get this darn thing over with at this point. And I will be quiet now and pass it on to Dr. Kasirye.
Hi, everyone. Thank you for joining us again. So, of course, speaking of viruses circulating, what do our numbers show? We are at 147,026 cases of COVID-19 reported to Sacramento County. We're averaging between 300 and 400 cases per day. And our case rate, the latest case rate is 21.2 per 100,000. So we have seen a steady decline for the past 2 weeks. I know that the last time we had this call, we were saying that we were cautiously optimistic. It does seem like we are on the downward trend, and it's true for the state in general. With the deaths, we're at 2,120. We're averaging anywhere between 5 to 10 and sometimes 15 cases, our deaths per day reported. So what usually happens with these surges is initially you have an increase in the numbers of people that are testing positive, then you'll see an increase in the hospitalizations. And then in about 2 weeks after that, you'll start seeing an increase in the deaths. So we anticipate that the deaths will continue to be high for quite a while, partly also because it takes us a while to be able to get the numbers or the documentation to verify that this needs to be counted as a COVID death. For hospitalizations, as I mentioned, now that we have seen the increase in numbers for about 2 weeks, we are beginning to see a reduction in the hospitalized cases at 310 and the ICU at 82. So the hospitals are not quite as impacted, but some hospitals are busier than others. We're told that the emergency rooms, and of course, Dr. Cohen can speak to that better than I, but that the emergency rooms are still busy. So we still ask that people who are looking just for a COVID test go to other places. We have a lot of other places in the community where people can get the COVID test. One thing that we're asked a lot about is what's happening with the children. After the schools started in person, we started seeing an increase in cases among children. So now they constitute about 20% of our cases being reported. Fortunately, the hospitalizations have remained quite low, about an average of 3% of hospitalized cases. So that is fortunate. It's not the case that we have seen in some of the other states, like in the Midwest, where we've seen their pediatric floors completely full. So we continue to monitor that, but I think it's a good sign since our numbers are already reducing that we will not see that impact. Turning to vaccinations, we are at 54%, and this is of the total population. 54% are fully vaccinated and 60% have at least one dose. As Dr. Cohen pointed out, one of the topics that's being discussed quite a bit lately is about what we're calling either the booster dose or the third dose, depending on the status of the person. So usually we talk about third dose when we're talking about people that have immune compromised systems, where they need that third dose in order to get the full level of protection. And then the booster is usually for those that have had good protection for a while, but it starts to wane after the 6 months. And FDA gave a recommendation not too long ago to include people over the age of 65 in certain occupations or settings that put people at risk, which included healthcare and teachers. But today, just before this call, we were informed that the CDC voted only to approve booster doses for those over the age of 65. So just to let you know there that the Western states do have another advisory body that looks at all of the information and their recommendations from FDA and CDC and makes their own recommendations. So we still have to wait for that before we will know what we're going to do in Sacramento. So right now, there is approval for people that have immune compromised systems, and most of them have been able to access that through their own healthcare provider. And we do have a tentative plan in place, but it will depend on how the booster doses are rolled out in order to understand what kind of additional resources we will need. So with that, I'll turn it back to Liz.
Sounds good, thank you. All right, so just as a reminder, you can use the Q&A function on the bottom of the screen in order to submit your questions. And we will do our best to answer all the questions we can during the time that we have. So we have a question from a community member about events. Many events, such as concerts and sports games, are requiring proof of vaccination. Just how really COVID safe does that make said event? Is there still a lot of risk?
So large crowds do have carry a risk, especially if they're indoors. It's less of a risk if they're outdoors, but again, if there's no social distancing, there is a risk. Being vaccinated or having everybody show proof of vaccination does provide a lot more protection, because we know that people who are vaccinated, one, even if they do have the disease, they are infectious only for a short time. They're less likely actually to get infected, and less likely to be infectious, and also get much milder symptoms and milder disease. In addition to the proof of vaccination, most of these large events are also requiring that for people who do not have that proof, that they have a negative test. So again, that's an additional layer of protection. The other layer of protection is requiring masks. So all of these are different layers of protection, but I think it does come to an individual decision, especially for people who have compromised immune systems. I think that you really need to think hard about some of these large events and whether you should attend or not.
Awesome. Thanks, Dr. K. That's really helpful, as I'm sure a lot of people are considering their choices in the coming weeks and the coming months. So I know you all mentioned the third dose. That's of top of mind for many community members. How will the county administer the third dose? Will appointments be needed, and when is the expected timeframe?
The good thing is that this time around, as opposed to when we first rolled out the vaccine, we have a lot more resources in the community. A lot of pharmacies are offering it, doctors' offices are offering it, the healthcare systems are offering the vaccine as well. So there are a lot more options. We still continue to focus on the first and second dose, but we're also monitoring to see what the demand will look like for people who need the booster dose once that is approved. And we still have a lot of volunteers that have worked with us and have said that they would be willing to mobilize again if we needed that assistance. So we have a tentative plan. It's all dependent on what the demand will look like.
Thanks, Dr. K. And it looks like we have some volunteers on the call who have identified themselves as working with the effort. So just wanted to say thank you for the work that you've done for throughout the pandemic. We really appreciate you. We have a community member that's saying it's likely that the COVID virus will not go away, and we just need to learn how to live with a certain level of risk. We're approaching 2 years and it's not gone. Is this the new normal?
So I guess I can mention a couple
Yeah.
of things. I do think it's the new normal. I think here's the deal. So we know that coronaviruses have been circulating for forever, right? They're one of the most common causes of routine common colds. And I think that what we have seen with COVID-19 is that as time goes on, the number of cases go down, and even with the Delta variant breaking through and other viruses breaking through, we're going to have a better handle on things. I've talked about this, and I don't know whether Dr. Kasirye actually will agree with me, because a lot of it are sort of my thoughts, and I'd be interested to hear what she has to say. But we've been developing vaccines and putting together strategies for managing this pandemic while it's raging on. And so maybe having 3 doses is the right number of doses that you need for this vaccine. We do that with hepatitis B. We do that with tetanus, right? When kids first get tetanus, diphtheria, and pertussis, they get 3 doses of vaccine. There are a lot of vaccines that require more doses, and that's sort of the balance of trying to control a pandemic and optimizing how we're going to get things under control long term. So yes, I don't think this is going to go away. And yes, we do have to live with a certain degree of risk. But I think as people become better immunized, I think the chances for long-term complications and for more serious disease may decrease over time, right? It's the same idea as that if I get a breakthrough infection after getting vaccinated, the likelihood is that I'm not going to land in an ICU. Whereas before I was vaccinated, I'm 68 years old. I have some underlying illnesses. I might well have been somebody who died or who landed on a ventilator. So I think that it changes the risk. Yes, people are going to get infected over time. And yes, we're going to have to figure it out. I think right now, I think the reason that people are a little bit leery about getting back is because there's still a little bit of a fear of the unknown. And while we've been dealing with this for 19 months, we really haven't been dealing with it for but 7 or 8 months where we've had a significant number of the population vaccinated. And I think we're still trying to get our sea legs, so to speak. And you see this, right? I mean, we have kids back in school. We have, here I taught a class in the medical school today that was in person. That's the first time I've done this in a year and a half. And so I think we are starting to live with it. I think you can understand why people are a little bit reluctant to jump right into it. But it'll happen. And I think, if we had the bulk of the population vaccinated, we'd see that this is better. I mean, it's better in California than it is anywhere else because we have a high rate of vaccines, and we have a lot more immune people. What do you think, Dr. K? Do you agree or not? You don't have to. Now you're the one that's muted.
Yeah, I was trying to get off of mute and there's something covering it. So I was like, okay, what's going on? I think one of the things is that we're all going through this for the first time together. So there's information that we're able to get as the researchers are providing us with projections. But then we do get some surprises, such as with the Delta variant. Because if you recall, in June, our numbers were really low, like we went down to 4 per 100,000 case rate. We were at the point where we were telling people that are vaccinated that they did not have to wear masks. And then here comes the Delta variant. And so we're back to masking, but it's not the same as it was when we first started, because with the vaccinations, there is a lot more protection. And for people sometimes who are, asking us questions about whether the vaccine is really helping, what I point to is the long-term care facilities. In previous surges, we had large outbreaks in long-term care facilities and a lot of deaths, because that is a vulnerable population. 80% of our deaths were in people over the age of 65. But now, because the vaccination rates, especially in long-term care facilities, the residence is really high. Many of them are 90 to 100% vaccinated. This time around with the Delta variant, we've had much fewer outbreaks, and they've been much smaller, and the deaths have been lower. So I think those are things that we can point to see that, okay, this is the path forward. And that's why we are promoting the vaccine, because we do have a lot of evidence to show that it's effective. And if you look on our dashboard, we do, under the vaccination tab, we do include information about case rates among those that are vaccinated and those that are not vaccinated. And this is true not just for Sacramento, it's true for the entire state. You see that for those that are not vaccinated, the case rate went as high as 70 per 100,000, where it remained about 10 per 100,000 for people that are vaccinated. So there is protection. I don't know what the normal will look like, or how long it will take us to get to that normal, but I know we are heading towards that. As Dr. Cohen pointed out, also this year we were able to have children in schools, and we've been able to keep the schools open with being able to have the masking and testing. So we're navigating it, and we'll get there. But everybody just needs to be patient. One thing I wanted to point out that we're asked a lot about is, well, if the way to get to it is by immunity, how about natural immunity? And I'll let Dr. Cohen talk a little bit about natural immunity, but what I've been saying is that, one, there's a lot that we don't know. And for me, telling folks that, the way forward is with natural immunity. We know that there are a lot of risks for people. It's basically playing Russian roulette, because you don't know whether you're the one who's going to get a severe disease, end up on a ventilator, end up with severe damage to your lungs or other complications. Whereas with the vaccine, you just get the prick, you may get some side effects, and then you're able to move on and you get the protection. So I think we just need to look at the evidence and understand that the vaccines are effective and be willing to get vaccinated.
Yeah, I agree. I mean, we know that natural immunity with any coronavirus infection wanes over time. Right, that's why we can get colds multiple times, right? Because the immunity doesn't last forever. And even if the virus doesn't change, the immunity wanes. And I think, the Delta variant, because the amount of virus that grows in the airway is so much higher, it's so much more easily transmitted that it becomes more obvious that maybe the immunity has waned a little bit, either natural immunity or with the vaccine, that might not have been seen with the older variants because it wasn't as easily transmitted, and you didn't need as, and you weren't being exposed to as high number of virions. So I think, the expectation was going to be that this is probably going to be like influenza anyhow, where we have to get vaccinated annually because immunity is going to wane. And it wanes with natural infection, probably similarly or potentially more rapidly than with vaccine, because the amount of antibodies generated with natural infection tend to be lower than the amount of antibodies that are developed with the vaccine. So assuming they all sort of decline at the same rate, starting higher is better than starting lower, and the immunity will be a little bit longer lasting.
Sounds good. Thank you all for your nuanced response to what might happen in the future. I know it's a really hard question, which is why it required some additional thoughts on what that might look like. So we have a community member, Ruslan, who is wondering about statistics on vaccination rates across the Slavic community in Sacramento. Last year, we heard about a large outbreak in one of the Slavic churches, and we're getting a lot of alarming messages from our readers. Folks are confused and misinformed. What are the efforts to spread awareness on COVID-19 and vaccination in our community?
Last year, we were able to identify an increase in cases in the Slavic community, and we worked with the church and worked with the community as well. It's not as easy to distinguish because the way that our data comes in, the Slavic community is all included in the white group. So unless we do a deeper dive and look at the names, and then we're able to distinguish if they are from a certain community, such as the Russian community. So we have not done that this time, but what we have been doing is, as part of our response, is working with the different groups, communities, such as the African American, the Latino, and the Russian, to find what we call trusted messengers. You've probably heard people talk about that quite a bit. And basically what that means is finding community-based agencies that provide services in that community, or community leaders that are already recognized and respected, and working with them to continue to put the message out, to encourage people to get vaccinated, and also to dispel some of the myths or misinformation that often is spread through social media. So a lot of it is working with the communities and finding people that are able to give the correct message, and also actually to assist us in having the vaccination clinic. So again, you mentioned that we have a volunteer on here. So I just want to put a shout out to all of our volunteers, because there's no way we could have done all of these clinics without the assistance of the volunteers.
Thank you. So Katie is wondering, don't you think it's reasonable to not require a booster that does not address the Delta variant?
Well, I saw that question, and I was trying to figure out what the question was asking. So I'm thinking that what you're asking, and if I'm wrong, please add something back to the Q&A. So I'm thinking you would like a booster that actually directly targets the Delta variant. So, so what I have seen from the limited data that I've seen is that using the same vaccine that we got the first time raises antibodies high enough that it inhibits Delta variant equally effective to those that have variants in the investigational vaccines. I think part of the reason that the variant vaccines are not moving forward is that it would require a whole another set of approvals to get things moving along. And it appears that using the standard vaccine is good enough to get immunity built up to the Delta variant. I think long-term, the other potential is that this is going to be a multivalent vaccine, again, just like flu. When you get a flu vaccine now, there are 4 strains of influenza in it. It may be the same kind of thing ultimately with the COVID vaccine, but again, this is trying to get vaccine available to people as quickly as possible. and providing the best support that can be provided by doing it in the quickest time frame. Right, I know actually Moderna's already looking at a vaccine that's combined COVID and flu vaccine. So I think that's sort of the one of the ways that people are moving forward. But right now, when we just need to get people vaccinated, we need something that's been through all the tests, been approved, and everyone's happy with it, and move forward.
Sounds great. So Debbie is wondering, is it possible for me to get a test to determine my level of antibodies? If my antibodies are not high enough to protect me, would there be a level that I would then need the booster?
That's a terrific question, and one that is a little tough to answer. So there are several different types of antibody tests that people can get. One is a qualitative test, meaning it just tells you whether you have antibodies or don't. The other is a semi-quantitative test, which tells you sort of how much antibody you have, but it's a scale. It's not an exact number. And then there are antibodies that target the spike protein, which is what's in the vaccine, and then antibodies that target the nucleocapsid, which is actually not in the vaccine. And if you had antibodies to nucleocapsid, that would mean that you actually had natural infection. To my knowledge, and again, I will yield the floor to anybody who knows better than me, to my knowledge, there is not a clear number that is defined that will say this is a protective number. So for example, with hepatitis B, we know the number is 10. And if you get antibodies above 10, you're protected. And if it's below, you're not. Assuming you've never gotten above 10 in the first place. I don't know that number right now for the COVID vaccine. What an antibody test would tell me is if I've developed antibodies at all versus not developing them at all. I think you're going to want to get boosted anyhow. And so I don't think it's going to change your decision. It might provide you a little bit more confidence if you at least knew you had a reasonable amount of antibodies than if you had zero. But right now, I'm testing people if they ask me, but I don't routinely order them because I don't think it helps really make a good decision.
Thanks, Dr. Cohen. So as we all know, it takes a team to do this work. So I'm gonna have my colleague Carlos jump on. I'm gonna add you here, and Carlos is going to take the conversation from here.
All right, thanks, Liz, and hello, everyone. So I'm going to pull up my question list and keep it going. So let's go back to Katie. Do you still plan on recommending a vaccine for males under the age of 30? With the new information presented at last Friday's FDA meeting regarding increased risk of myocarditis.
People who are actually getting myocarditis. The data that I've seen says that it's short-lived. It doesn't go on for prolonged periods of time. The patients recover without any long-term complications. And the other point would be that if somebody gets COVID, they can get myocarditis too. And sometimes that becomes more severe and maybe more long lasting. I'll point out one other thing. So everyone remembers that at the beginning of last year's college football season, some conferences decided not to start playing right at the beginning of the year. Some didn't play all year long. And part of that was driven by a study that was done at Ohio State that showed that younger athletes that got COVID ended up having myocarditis when they did special imaging, and that they didn't want to risk their athletes ending up with long-term complications from the myocarditis. It turns out that that number is a modest number, and that very similarly to with the vaccine, the myocarditis generally gets better. So, so I think the risk is there whether they get infected or not. So it still weighs in my mind towards giving the vaccine, which is actually what the FDA still said, even though they commented on exactly what you've noted, that younger men are at higher risk for getting myocarditis.
I want to clarify a couple of things. What I mentioned in my introductory comments was I said that children, school-age children, so those are 17 and below, that's where we have seen an increase in cases as they've gone back to school, but the hospitalizations have remained low. When you look at our cases, the highest number is in the age group 18 to 49. And right now, especially with this Delta surge, the hospitalizations, we're seeing younger and younger people in the hospitals. So my thought is that anyone in the 20s and 30s, they're at much higher risk of getting infected. They have a risk of, especially with the Delta variant, of hospitalizations. And so they do need to get vaccinated. I think in terms of for the males, as you mentioned, the complication of myocarditis has been noted. There have been relatively few cases, mild cases with no deaths. And as Dr. Cohen noted, that the symptoms are transient and they do recover completely. So I think those are all things that need to be considered. If someone is concerned about getting one of the mRNA vaccines, they can get the J&J. And so I think, again, it's one of those where you're considering different risks, and the risk of myocarditis due to COVID infection is much, much higher, much more severe than what has been noted with some of the mRNA vaccines.
Great, thank you. I just want to go back to the question around antibodies. So Debbie's asking to continue her question. So how do I get a booster if I am under 65 and I don't know my level of antibodies?
So first, eventually everyone's going to end up getting boosters. So at this point, 65 and older is the group. But you remember, even with the first doses of vaccine, it was rolled out to older people first. It was rolled out to people in high-risk circumstances and people whose immune systems were potentially compromised. So I think that that you will get boosted. If you were to get an antibody test, if you had your physician get an antibody test and it was 0, then they might be able to justify getting you vaccinated, because they could argue that your immune system's not working quite right if you had no antibodies. But in reality, we sort of are locked in by the way that the drug is approved. and how the vaccine is being rolled out. I think there are a lot of people who want to get boosters right now. As I was saying, I think our medical staff wants to get boosters. And I've already heard a bunch of stuff from people who are under 65. And so we'll wait for the Western states' decision as well. But I think the fact is that ultimately everyone's going to get boosters. And at this point, I don't think you can justify giving a booster to somebody under 65 just because their antibodies are low, because there's not really that indication. You know, I don't make the rules. I just sort of follow them.
All right, thank you. Let's see here. Is the booster vaccine the same vaccine formula as the first two vaccines?
Yes, it is.
Okay, that's an easy one. Let's move on from vaccine just for a second here. Question from Debbie: has Sac County seen cases of the Mu variant?
Yes, we have. I think we have not put them on our dashboard yet because it's the number is less than 5. So we have seen a few cases. I don't remember whether it's 3 or 4, but once we reach over 5, we will be able to post it on our dashboard.
Awesome, thank you. All right, so for events and or workplaces where vaccination or proof of negative COVID-19 test is required for attendance, will consideration be given for folks that have developed natural immunity versus vaccine-induced immunity? For example, they can show antibodies via a serological test.
Antibody tests are not, they're not permissible or permitted. So it has to be either a negative test, either PCR or antigen, which tests if you have a current infection, and then the other is proof of vaccination.
Okay, and because there is so much virus made by the Delta variant, have we seen a smaller proportion of asymptomatic positive cases?
That's hard to say because we don't always have that information. I did see a question on here about the number of, because we do have that information for the vaccinated. We're able to get the number that have symptoms and the ones that do not. But as I mentioned, we don't have it in every single case. So it's hard to say. I think from the studies, and Dr. Cohen, correct me if I'm wrong, they did say that the Delta variant people tend to have, there's a higher proportion that are symptomatic.
Yeah, I agree. And I think in the asymptomatic screening that we do at UCD, people may test positive, they may not have symptoms, and then they'll have some symptoms a day or two later. So there seem to be a low percentage of people who have nothing at all. It may be super mild, it may just be a scratchy throat or something along those lines. But if you ask, most people have some symptoms. They may not have classic symptoms, including fever.
Great, and perhaps a clarification from Dr. Kasirye when we were talking about tests that are permitted for folks that don't get vaccinated. The question is, so antibody tests are not permitted by whom?
The state health order outlines what tests can be used. And as I mentioned, it's only the PCR and antigen.
Okay, great. Here we have a question from anonymous attendee. I want to thank the county for reporting on its numbers of breakthrough cases. It was startling to me that only 23% of the breakthrough cases were symptomatic. I'm assuming that these vaccinated people got tested because of contact, travel, or other requirements. It's difficult to get this information nationwide or statewide. Could you comment on the relatively high proportion of asymptomatic breakthroughs? Is this really reflective of our community? And if so, we really need to do to remain vigilant, and masking seems more likely to be needed until we reach a higher level of vaccination in our community. Sorry, that was a lot of words.
Yeah, and I think that's one of the points that was made at the national level, is that individuals that are vaccinated, that they tended to have milder symptoms or no symptoms at all. And actually, that's some of the data that earlier on in the summer, when we looked at that, that's why we made the decision that everybody, regardless of vaccination status, should have a mask, use a mask indoors, because indoors there's a higher risk than outdoors. One of the questions that have been asked a lot is, when are we going to end that masking order? It is dependent on the numbers, and we continue to monitor. We're also, of course, coordinating with other counties that have this masking mandate. My hope is, especially looking at the way the numbers are going, that we will get to that point where it will become voluntary for people that are vaccinated. But right now, I think we still need to continue monitoring.
Okay, thank you. Do you have any tips for obtaining a test required for modified quarantine, so that my relative who was notified they were exposed and needs 2 tests may continue to attend middle school?
So modified quarantine is only for students, and the state does give the criteria for when we can use a modified quarantine. Basically, that means that the person who was exposed and the person who had the infection were both wearing masks, which means that there's a reduced risk. And this allows the student to be able to continue to attend school. They cannot attend extracurricular activities, but they're able to attend school, and then they get tested twice a week. Most of the schools do have the resources to do the testing. And of course, they use the antigen test so that they can get results with a quick turnaround. I think if you are having some difficulty with that, we also do have several, and I believe that Liz did put the link, provide the link that you can actually go to one of our community sites and get the testing as well. But of course, there's a lot more, it's a lot more convenient if you're able to do the testing at school.
Awesome. So Debbie has a question. What type of exposures lead to getting COVID? Is it a function of viral load and length of time of exposure? Will I get COVID walking by a person who has tested positive?
Yeah, there are a lot of factors that go into determining the risk of an exposure. And so that's why we, when we are doing our contact tracing, we talk about things like whether the person was wearing a mask, how long they were in the presence of the person who had the infection, the distance, because if it's more than 6 feet, then that reduces the risk as well, and whether it was indoors. And also, of course, it depends on the air circulation. So that's why with the schools, in order to reduce the risk, we talk about the masking, especially indoors, and also making sure that you have good ventilation. Those are all things that reduce the risk. If you're just passing somebody, it makes it difficult unless somebody happens to talk very closely to you, sneezes or coughs in your face. Yeah, that will increase the risk.
Yeah, but just walking by somebody is probably not going to be what you would define as a real risk, right? I think, I don't know, do you, so when we do our tracing in the hospital, we look at exposures as being unmasked, or at least one of the two people being unmasked, and then somewhere in the range of 15 minutes of exposure. And so I think, again, it is, you know, you have to get a certain amount of virus in your body in order for the virus to evade the local immune responses and what we call innate immune responses to get infected. So I think just walking by somebody, it would be less likely than getting hit by lightning, I think, you know. We never say never in medicine, but it's pretty close to never.
Fair enough. So back to the testing question. I think there's some concerns around availability of tests. And the question really is, will testing sites be increased? This community member feels like it's needed.
We are not at this point planning to increase the testing sites, at least the ones that the county is running. There are a lot of other available testing sites. I believe the city of Sacramento has a contract with a different agency that is providing these kiosks for testing. A lot of the pharmacies are able to do the testing, and a lot of clinics too. The community testing sites that we set up were really geared towards individuals that have difficulty with getting to some of the other sites, whether it be because of transportation or other barriers. We are monitoring to see how those, what the usage of those sites is. And recently, when there was an increase in demand, we did increase the number of hours as well as increase the staffing to be able to minimize the wait time.
Yeah, and as we update, I just want to add that as we update testing resources for folks to check out our testing website, and we'll update with additional hours and locations. Okay, so moving on. Why do California hospitals not allow monoclonal antibody therapy to be given if admitted?
I don't know who doesn't allow that. We give it. Let's put it this way: the way monoclonals work and the way they work best is if they're given very early in disease. So if somebody happens to be hospitalized, maybe because they got in a car accident or for some other reason, and they get tested as part of our routine screening, and they have mild symptoms, but they're a high-risk person that, let's just say they're a poorly controlled diabetic or something like that, we'll give them monoclonal antibodies. I think the issue right now, for at least for us, and we've given a lot of monoclonal to people at UCD, is that the amount of monoclonal is now in shorter supply, and so we're getting allocated again like we were at the beginning. So we had expanded testing, because the other way that monoclonals work, and there was a recent publication in New England Journal of Medicine, a study that we actually participated in with family contacts of people with COVID, where it effectively prevents infection in a significant number of people who are family exposures. So monoclonals are great. They work really well early. Where they don't work in the hospital is if somebody's already sick and on a ventilator. The studies have shown that they don't provide any benefit. So you got to get it early. And in my opinion, if somebody's hospitalized with mild disease that's early and they're a high risk person, I have no problem giving them monoclonals.
Okay, and why hasn't Sacramento County done anything for early outpatient treatment?
I can't speak for the county, but I think that they make the monoclonals available to us. And so it's up to individual health systems or practitioners to be able to provide monoclonal. We've done outreach. We have given monoclonal to people who are not part of UC Davis Health. If we're contacted by outside physicians who don't have access to monoclonals. So I think and that's really the only option we have for outpatient treatment that's been shown to be beneficial. I think there are a lot more studies that are ongoing. I think patients are getting tired of participating in clinical trials, or at least that's my impression. We have been involved in many of the clinical trials. We were involved in the early trials with remdesivir and with other combinations associated with remdesivir. And as time went on, the number of patients that were willing to participate went down because they had more options for treatment. Most of the therapies were initially designed to treat people who were at high risk of dying in the hospital. That was the number one goal. Now the goal does need to be exactly what you're suggesting, which is that we get people treated as outpatients and keep them from getting sick enough to be hospitalized. There are drugs. I think there are drugs that are, we still have clinical trials looking at outpatient treatment. We just have a hard time getting people enrolled. People feel like if I'm doing okay now, I'll be fine. And if I'm not, I want to get monoclonals. I don't want to participate in any trials. So it makes it a little bit more challenging to develop these new drugs like we have for influenza, right? I mean, that's what we do with oseltamivir, with Tamiflu. We give it early. And again, that's a drug that works better if you give it early in disease, and we keep people from getting sick enough to be hospitalized, right? So that is the ideal is to not get people in the hospital. The ideal is not to have to treat somebody who's stuck on a ventilator. The idea is to get people treated early and keep them from getting too sick to be hospitalized. I'm in favor of that. I don't invent the drugs, and so somebody has to come up with medications that will work in that setting. Again, I think we've been pretty generous in our criteria for giving monoclonals, and we've had a lot of patients benefit. I've had people call me back and tell me how much better they felt, and have been appreciative about it. So I think maybe sometimes reality and perceptions are a little bit different. I can't speak for other health systems. I don't know how they're working.
All right, thank you for that, Dr. Cohen. And I think you touched on this, but just to put a bow on this, is there anything new available for treatment of COVID? And someone suggests, I might be butchering this, but budesonide, azithromycin, In their, I guess they saying that these are treatments that other frontline doctors are using around the country. Can you speak to any of that?
Yeah, so budesonide is a inhaled steroid. And there are studies that suggest that budesonide, because it's an anti-inflammatory drug, may limit severity of COVID. They're small trials, they need bigger studies. Azithromycin has been studied in bigger trials, it doesn't work. Right, again, azithromycin is an antibacterial drug that we normally use to treat bacterial type infections. But it does have an anti-inflammatory component to it. And we sometimes use it in people with bad lung disease just to keep the inflammation down. But the clinical trials that I've seen with azithromycin, it doesn't work. So other physicians who may be using it, it's available, right? I can write a prescription for azithro, I can write a prescription for budesonide. They're both available through pharmacies, but the data to support their routine use is not present in my estimation.
Great. Should non-essential offices reopen for in-person operations at 100% capacity when there could be visitors or deliveries, et cetera, with unknown vaccination status?
That's a question that I think is easier to respond to with an assessment of the business itself, because there are a lot of factors you need to take into consideration. There are some facilities such as healthcare where they are required to ask about vaccinations, but it's not true for all of the businesses. Some of the businesses, they are able to continue to maintain the social distancing because people sit at their cubicles, and they also have additional guidance such as mask wearing indoors, and also that they ask that anybody who has symptoms should not enter. So all of those are things that the business has to consider before deciding whether people should be able to get back to in-person services or not.
Okay, thank you. A question about PCR testing. So is it true that PCR testing has been phased out due to it being an ineffective diagnostic?
No.
I'll start and then I'll let you continue. That question has come up a number of times. I think where the confusion came in is that the CDC that produced or got the emergency use authorization for the first test that was used in the United States put out a statement saying that they were going to end the emergency use authorization at the end of this year. And so people thought that maybe that was because there was something about the PCR. There are statements that the CDC has subsequently put out to clarify that the reason that they are withdrawing the EUA application was because there are a lot of other PCR tests that are available. I think if you go to the FDA website, you'll find that there are about maybe 35 or more that are available. PCRs are very accurate. They are actually what we're using as a gold standard for clinical diagnosis. And I think it's important for people to remember that we use PCRs for a lot of other diseases as well. The value of the PCR is being able to get a relatively quick turnaround time. I'll give you an example. We use them in diagnosis of TB. Before we had PCRs with TB, it used to take us anywhere from 8 to 12 weeks to get a culture result before we could know if a person really had TB or not. But with the PCR now, you're able to get that within a very short period of time, 24 hours to 72 hours. So, and it's very accurate. It's never been put into question. So it's the same thing with the COVID during COVID. The PCR is very reliable. It's over 90% accurate, which is pretty accurate for any test. And the last thing that we've had people ask us about is its ability to distinguish between COVID and the flu. It does that very well. It's just that right now there are versions called the multiplex, where the test, and Dr. Cohen probably can speak more to it than I can, that are able to simultaneously test for the flu and COVID, so that if you take one specimen, you're able to either rule in or rule out the two at the same time, rather than taking multiple specimens.
Right, so the PCR test is the most sensitive test that we have. Most of the PCR tests target genes within the SARS-CoV-2 virus that doesn't mutate like the spike protein does, or some of the other proteins, so that it's less affected by variants than an antigen test, for example, whose sensitivity can be impacted by the variants, in addition to just being less sensitive to start with. And I just point out that when the antigen test became available, the thought was that this was a perfect test for testing people daily, right? There are a lot of workplaces that do daily testing, right? The people just swab their noses. They do an antigen test that looks like a pregnancy test, or some of the other tests where you just look for a little line that shows up, and that's a positive test. They work great if you do them that frequently like that. But as a one-time test, they're only about 70% compared to a PCR. And so I think that it really does make a difference what type of test, and people who get positive antigen tests, even when they do daily screening, end up getting a PCR to confirm it, because no one's 100% certain about the antigen test. So it is the gold standard. There are some that have fallen off the market, in part because they were designed to target spike proteins where they're missing a lot more. But the ones that are left, they are designed to not be affected by the mutations of the virus.
All right, thank you for those answers. We have a question. If you could comment. If you could comment on the VAERS reporting system and how. Okay, I think we can hear the interpreter. Okay, let's try again. Could you comment on the VAERS reporting system and how few practitioners are using the system?
So, do you want to go ahead? Go ahead first. And then
I was just going to say that, I mean, we all know the system exists. If we see vaccine toxicities, just like we know that these same systems exist for any drug, that if you find what you would define as a significant side effect, you should report it. I can't speak to why physicians are not doing it, assuming that you're correct and they're not doing it. I can only speak for myself. I use the system when I need to use the system.
Yeah, and I just want to point out, because the VAERS system has been brought up a couple of times. And I think the best thing is for you to go to the VAERS website and read the information that is provided, the FAQs that are provided about that system, so that you know how to interpret the data from there appropriately. Basically, the reason it was set up is so that anybody could input information about an adverse event. So it could be a physician, could be a hospital, could be a patient. Anybody can put information in there about an adverse event. And what that system does is more like an early warning so that the FDA and the CDC are able to monitor. And if they see a certain pattern, they're able to go in, request the records, and then find out if there really is a connection between the adverse event they're seeing and the vaccine. If you read the FAQs that are provided on the website, it says very clearly that not all of the information on there is verified. So people should not be using it to make an assessment about the safety of the vaccines, because that is unverified information. The CDC and FDA have been monitoring very closely, and whenever they've identified anything, they have been able to go in and do an assessment to find out whether there is a connection or not, and provided that information to the public.
Great, thank you. We have a question from one of our MRC volunteers. Will there be a need for volunteers again for third dose and/or flu clinics?
We don't know at this time. It will depend on when the approvals will be given for the third dose or the booster doses. But thank you again for volunteering. We will let you know. Please make sure that we have your contact information.
Great. Question around a masking mandate. How is it possible that all counties surrounding Sacramento don't need a mask mandate or don't have a mask mandate, but Sacramento does? Shouldn't we be seeing mass cases in all these other counties?
You bring up a good question. There are a lot of factors to look at. I think one thing you need to notice is that Sacramento County is a much larger and more urban setting than many of the surrounding counties that we have. And we know that with urban settings, there are more people, and so more opportunities for spreading of infection. There are a lot of factors to consider. There's vaccinations to consider. But as I said, the reason that we decided to issue the masking mandate was as we were looking at the numbers, especially at the beginning of summer, and seeing the rapid increase, as well as the evidence that there could be people that were vaccinated were at risk as well. We took that step to pass the mandate, and will continue to monitor along with other counties that have passed the masking mandate, and make decisions as to when we can end it.
Thank you. So we probably have time for hopefully 2 or 3 more questions. So let's go to why isn't it a HIPAA violation to ask a person's vaccine status?
The HIPAA violation, if you read the law, there are specific information that is considered necessary to make it a violation. Basically, when you're getting specific information about a person's specific disease conditions, for example, especially some of the more sensitive ones like HIV. But with the vaccine status, we're basically, we're not asking you about any disease conditions that you have. We're just asking to find out if you've been vaccinated, and therefore, meaning that these are public health steps that we take to be able to ensure that when people are congregating, that it's as safe as possible. We routinely ask for vaccinations for schools, universities, and even especially for international travel. Even prior to COVID-19, you would be asked to have certain vaccinations. And in fact, in some countries, you would not be allowed to enter if you didn't have, for example, the yellow fever vaccine. So these are basically not included because they are public health of public health importance.
Thank you, Dr. Kasirye. Okay, let's try this one. How does a vaccine that still allows transmission end up stopping the viral speed? Or
Right. Yeah, so there are a couple of things. You've probably heard us talk about what we call the herd immunity, or now we've changed that to talk about community immunity, meaning that the higher the number of people that are protected, the more difficult it is if a certain group has somebody who is infected, the more difficult it would be for that certain disease to spread. There's also in epidemiology, we talk about what is called the R effective, which basically means that if someone is infectious, in general, how many people do they infect? So if it's above 1, that means that you have a lot more people that are getting infected, and the transmission is much higher. But what happens is when you have people that are vaccinated, the more people that are vaccinated, it effectively reduces that that opportunity for transmission. And actually, you will see that with time, that are effective, which is one of the things that epidemiologists monitor, will continue going below, lower and lower and get to below 1. And that's a good sign that you look for. So I mentioned, for example, with the long-term care facilities where we have 90 to 100% vaccination of the residents. And you can see right there that because of the high rate of vaccination, we didn't have a lot of transmission there. And with time, if we had the same level of vaccination in the entire community, we'd get to that as well.
awesome, thank you, Dr. Kasirye. And I do have 7:28 here, so I'm gonna stop the questions here. So apologies if you did not hear your question. Always feel free to reach out to us at covid19@saccounty.net. Just want to thank the community for joining us again, Sacramento County Public Health, Dr. Kasirye, Dr. Cohen. Also, thank you to our amazing interpreters for their great work. I know they saved my rear a couple times today already. And so just want to see if our panelists have any closing thoughts. Maybe we can start with Dr. Cohen and then Dr. Kasirye.
Well, I always appreciate being on these discussions. It's interesting to me to hear what the community is interested in. I hope that we provide reasonable information. We know that information changes over time. We do our best to keep up with it, and we do our best to manage our patients as best we can. So thank you all for participating, and I guess we'll be back again in a month.
Yes, thank you. Again, we appreciate all the questions that you ask, and we hope that we continue to provide you with information that is helpful for you. We did have to change the week that we were having, that we usually have this forum because of the holiday that we needed to observe. But I think I will make sure that our coordinators, Liz, puts out the information for the next date early enough so that you are aware of which day. I know there's someone who's asking whether it will be 21st or 28th, and we'll give you that information very soon. And thank you again.
Thank you. With that, we'll end the webinar. Thanks, everyone.